Good morning. My name's Udvitha Nandasoma. I'm a medico-legal advisor with the MDU and I also work as a specialty doctor in hepatology. Thank you for inviting us to talk at Future Surgery. And this morning I'm going to cover a couple of medico-legal topics. They're going to be remote consultations and the GMC's new consent guidance, which becomes live on the 9th of November 2020. To move on to remote consultations first, I know some of you will now have had extensive experience of undertaking remote consultations, whereas for others it'll be something that was very new this year. It certainly was for me. This is the GMC's guidance on remote consultations. It's been on their website for quite some time, and it acknowledged that remote consultations were now becoming increasingly common, but also set a range of expectations as to when they might be appropriate and when they might not, with essentially them being appropriate for more straightforward things when you had access to records or knowledge of the patient and where the patient was able to engage with you. Now, whilst those principles still hold true, in response to COVID, the GMC kind of they reframed their advice in the context of simply high-level principles, essentially really quite basic things such as making sure that you're talking to the right person, being careful about the accidental breaches of confidence, and making sure that the person, because they weren't in your consulting room, was in somewhere appropriate where they could talk, and also when possible using approved clinical systems for undertaking this type of work. There was also a lot of guidance published on this for both primary and secondary care. It was suggested that remote consultations might be appropriate for routine chronic disease follow-up, administrative issues, counselling, and certainly a lot of psychological therapies, etc. have been delivered through this route during the pandemic, and also that they may be appropriate for triage, etc. when you might know that you will need to see a proportion of the patients face-to-face, but this may help you establish who would be. And most of the guidance placed some emphasis on trying to be sensible about the trade-off between the risk of bringing somebody up for a face-to-face appointment and the compromises you'd have to make in doing a remote appointment. NHS England also included some guidance of when a remote consultation might not be appropriate. They explain that it might not be sensible where you've got a potentially serious acute condition that was likely to need a physical examination that couldn't be deferred, but I must say my experience is that it's a lot of the practical issues, such as people who can't use the technology, don't have a good internet connection, or simple things like someone being hard of hearing, etc., that might make this mode of consultation very difficult. There are clearly important differences between a remote consultation and a face-to-face consultation. In a remote consultation you might have limited or no visual cues. Even if you had video, you clearly only getting a fairly defined view of the patient, and you may not have an adequate quality of video to do much with beyond simply establishing a rapport. And there are also other things such as olfactory cues or tactile cues that simply won't be there. And a lot of these things you may pick up on without even realising it during a normal consultation, and of course you won't have access to it through a remote modality. Of course, many of our colleagues in primary care get extensive training in consultation skills and structuring consultations, and this is perhaps not something we get so much of in our training as hospital doctors. However, I think if I were to give really one practical tip about remote consultations, it's making sure that you've got a proper structure to the consultation. Having an appropriate beginning where there are appropriate introductions, a check that you're talking to the right person and the patient's in an appropriate environment to talk can be helpful. As well as that, establishing that they know what the consultation's about and who it's with is really important. Now that some services are dealing with significant backlogs. Patients are receiving multiple appointments in multiple specialities, and they don't always know what a particular phone call or appointment's about, so it's important to kind of establish that. The second part of the consultation, the middle, is where you will exchange information, try and work out the patient's concerns, symptoms and problems, and give explanation as to exactly how you think that should be managed. Now clearly your usual skills of asking open questions, asking specific questions to identify certain points, listening carefully is really important. I'm sure that you're familiar with that from your face-to-face consultation skills, and this is not necessarily different. The one thing I would say is that actually the end of a consultation is probably one of the really important areas. And I'd say that that's because it's your opportunity to make sure that the agenda for the consultation has been satisfied as much as possible, and in particular to summarise and check the patient's understanding and to agree the next steps. I must say that when we started doing remote consultations in our service, we'd get a lot of inquiries about how would a patient get a blood test done, when would they next get their follow-up, how would that work out, and how would that be done, and actually proactively closing your consultation with a clear explanation of those points can really help. Having all appropriate safety netting advice, particularly when you're consulting about an acute problem, is also tremendously important, as is documenting that. Now, there isn't a huge amount of video consultation being undertaken at the moment, but it's clearly an area that will go. These are our kind of tips in that regard in terms of security and confidentiality. As the GMC guidance says, try and make sure that you're using an approved system when at all possible. Check and turn off the default recording settings unless the patient is aware of that, and that's how your system is set up to record the consultation. And make sure that you're using secure access to run the software as well. There are particular risks of trying holding identifiable information on your own devices, particularly if you have cloud sharing enabled, which may kind of back it up to your system, and which you may not delete it from your device even when you think you have. If you do receive any patient information onto a personal device, do make sure it's uploaded onto a trust system as soon as possible. And if you're consulting by video, then do make sure you've turned off your virtual assistants so you don't have those chiming during a consultation. There's lots of information out there about the kind of softer elements of video consulting, about establishing rapport, appearing empathic and properly lit, and all those sorts of things on video. Now, the thing I'd say about that is that I'm sure there are a lot more expert people than I to give you advice on that, but I'm conscious that we all work in environments that are not ideal. They may not be perfectly lit, the camera may not be in exactly the right position, and you may have to turn away from the patient or the camera to actually type on a computer system. The thing I'd say about that, and this really comes from our experience of GP complaints, when people have doctors will often be in rooms where they're having to access the computer system to get previous information and type notes at the same time during a short appointment slot, is that proactively kind of explaining what you're doing to the patient. So explaining that you're listening but might have to turn away, explaining that they may hear typing as you make notes about their consultation, and explaining any external noise, if there's building work going on in your hospital, etc., can be really, really important. Also, if you're consulting from a home environment and there may be distractions or noises, again, be straightforward about that, so that there's no sort of concern that the person's confidentiality is being breached, or that they need to be sort of nervous about what's going on in the background. I'll talk now a little bit about the medico-legal aspects of remote consultations. As we've said already, the confidentiality is a really important principle, and it plays out in a couple of different ways. There are the obvious things of, look, are you talking to the right person? But also think, are they in an appropriate setting? Are they in a private place where they can talk? A lot of patients, when they have remote appointments, will think they can have the appointments when they are out doing something else, or hairdressers, etc., and that might not always be appropriate. And of course, your appointment letters explaining what an appropriate environment is, what information it might be helpful for them to have with them, can help sort of mitigate those problems, but do check. The other thing is that if you're undertaking a face-to-face consultation, you will know who's in the room with the patient. Here you may not. Being explicit about that, I think, is helpful, clarifying who's present and in what capacity. And if there are other people at your end who are listening into the call or joining a video or a telephone conference, be explicit about that and explain why they're there and what their role is. And also be live to whether it's appropriate for them to remain in the consultation throughout. It may be appropriate for a family member to be present for part of a consultation and not another, and also always make sure that the patient's sort of aware of that option of having a private discussion when that's appropriate. In terms of consent, in terms of the consultation itself, in many instances, consent to the consultation may well be implied by the fact that they've had your appointment letter, they've picked up the phone and they say they're fine to have the consultation. But again, be mindful of how those things change and how the dynamics change, again, particularly with reference to the presence of third parties. Also be mindful of a sharing of images if a patient wants to send pictures to you or that to help facilitate a consultation, and also be particularly mindful about consent, third parties, etc. if you're thinking about undertaking what might amount to a remote examination. No, that's a relatively new concept, but again, there is guidance, particularly in primary care, about how to use near patient testing and also other techniques to make a remote assessment of a patient by telephone and video. Try and establish those parameters and be clear about them. There are also particular issues when you're consulting with children. Again, try and establish who's present. If an adult is present, it should usually be someone with parental responsibility. If that's not the case, try and establish why. Now, there can be certain circumstances where it's absolutely appropriate for a child or a young person to request to speak to you personally without an adult present, but perhaps you need to think carefully about those situations. Is the person sufficiently mature? Do they have capacity to consult with you in that way? Does it raise questions about safeguarding concerns? And perhaps these are the cases where you may have a very low threshold for a face-to-face assessment. I'm also going to talk briefly about record keeping. As you'd expect, the GMC guidance on record keeping isn't particularly altered in any way for remote consultations. And you can see that it expects that we record relevant clinical findings, what's been agreed, the information given to the patient, and what drugs, etc. are prescribed. Now, there are some additional things, though, you might want to record in a remote consultation. You might want to record how the consultation actually took place. Now, for most of us, we might kind of almost assume that a lot of what we're doing is remote, and it'll be obvious from the letter that that's how the consultation took place. But I must say that issues from clinical practice often arise years after the event, and sometimes it's very difficult to tell from the correspondence exactly how the consultation took place. So, I would certainly make it a habit to record how the consultation took place, whether it be by face-to-face, telephone, or video, explain why it was a remote consultation, record who was present, and if you had any concerns about the limitations of the remote consultation, acknowledge that and explain how you're going to address that. And again, take extra special care to carefully document the safety netting advice and follow-up plan that you've issued, and that'll be particularly helpful as often we copy letters to patients as well now. With remote prescribing, again, GMC guidance still applies insofar as you must satisfy yourself you've made an adequate assessment. You must think about the limitations of the medium and whether you need to do any other assessment, and also make sure you've clearly communicated administration instructions both to the patient, the GP, or if it's carers who are involved, making sure that they've got written instructions on what to do. The GMC has for a very long time prohibited non-surgical cosmetic products being prescribed by remote consult, and that still remains the case. So another area where we've had a number of questions relates to the sharing of images. I think this is something which can be done very effectively and routinely. Try and make sure that if you ask patients to send images in to facilitate their consultation, they understand exactly what's required. Do they know how to take a quality of image adequate to facilitate the care? And do they know how to get that to you in a way that means that it's received on a secured device or organisational system where it will form part of their medical record. Again, although you might think it's obvious, some patients don't expect their images that they've supplied to be stored on the record system. Make sure they know that it will be. If you're going to use the images for anything other than direct clinical care, you'd need to also record specific consent, and make sure that the person sending you the image has capacity to consent to that, and also that if you're dealing with children, you've got someone with parental responsibility that can organise, that can agree to that. Intimate images can of course raise specific problems. Think again about whether they're appropriate. If there will in any event be a need for examination or samples, then might it be appropriate to defer that to a face-to-face appointment. And again, although it may seem odd for a remote consultation, think about the issue of chaperones and whether one might be appropriate, particularly if you're consulting by video, and think also about whether trying to obtain an appropriate image will mean that a person who's frail may need help from somebody who perhaps isn't a trained healthcare professional, and again whether that's appropriate or whether it should trigger a face-to-face consultation. And again, be particularly wary about intimate images where it involves the under 18s. That can raise specific issues, and I think the most important point about that is to make sure that the clinical purpose behind requesting and receiving the image is very clearly documented. So I said I'd talk a little bit about chaperones, as this is perhaps something which we don't even think about for remote consultations now, but might become much more relevant as the use of video consultation is expanded. Chaperones are classically required, and certainly the GMC guidance requires that we offer chaperones for what's traditionally thought of as an intimate examination. So an examination of breast, genitalia, rectum, or any other examination which might make the patient feel vulnerable. It's there to primarily help and preserve the dignity of the patient, but be mindful that they can be a really important source of protection for the patient, for the practitioner, if concerns are subsequently raised. That's why, although a patient's relative or friend may be appropriate as a person to support the patient, they're not usually an appropriate chaperone, as that person should be suitably trained so they know what should normally take place during that procedure, that they're able to raise concerns if they think there is something amiss, and equally are able to provide reassurance if concerns raised later on when nothing was amiss. And as I say, this is something that is being thought about more, and there is some guidance particularly aimed at primary care about this already, though this document, as I say, gives a lot more information than that, and it may be something that's of just general interest in terms of seeing the direction of travel of video consulting and what might be possible in the future. So the next thing I'll talk about is the GMC's consent guidance. This is something which is available on the GMC website to look at and to inspect, and it comes into effect on the 9th of November 2020, and I'll talk about what that guidance changes in a little bit of detail later on, but I wanted to kind of talk about consent with a very brief history to kind of give you a bit of context to help you understand how we've got to where we are today. So the kind of slightly wordy statement on this slide is really the position that was classically the state of the law in the United Kingdom for a very long time, and it was last very significantly tested in 1985 in the House of Lords, as it was then, when in this case it related to a patient who'd had a very significant injury following spinal surgery, and the question raised was really how much information should have been shared with the patient at before the procedure was undertaken. And the view of the judges at the time was that really this was very much at the discretion of the doctor. It was really just like any other aspect of clinical practice, a matter which will be judged by reference to a reasonable body of medical opinion, and the Bolam test that kind of exemplifies that is what would apply. Now, even back in 1985, that was somewhat controversial, with the House of Lords being split and this being a 3-2 decision to maintain this position rather than move to what was a more patient-centred test. So many years after that, we have the GMC's consent guidance from June 2008. Now that very much moved the profession towards a much more patient-centred standard. There was a clear onus on doctors to share information. There was very specific guidance on the type of information which must be shared, and there were a number of bullet points of the types of things you had to tell patients about, some of which were very sort of plain, such as the benefits, burdens, risks of treatment, and others which were a lot more detailed, such as talking explicitly about the option of no treatment, talking about the fees involved, other people who might be involved, treatments available, and other centres which might better suit the patient, etc. Now that was in 2008. And then in 2015 there was another case which many of you will have heard of, called Montgomery versus Lanarkshire, and this was essentially a case relating to shoulder dystocia and a child suffering a brain injury as a result of complications of delivery. And again, this is will seem kind of somewhat out of date, as most obstetricians you talk to now would say, of course we'd warn of the risk of shoulder dystocia where you have a small diabetic mother and a potentially large baby. Just bear in mind that the events of this case happened in 1998, although it was finally settled and litigated in 2015. So here the law also moved in exactly the same direction as the GMC guidance did. It went away from that position in such a way of saying that consent is fundamentally an issue of medical judgment, and saying, look, a doctor's duty is to explain risks that would be material or relevant to a reasonable patient or that particular patient from what you know about them. So it's really on that background we have the new GMC consent guidance. In very many ways it doesn't change a great deal. The biggest change in their guidance was the changes from 2008, and the law almost caught up with the position that the profession had to adopt in any event a few years later, and now this is more of a change of emphasis rather than a wholesale change in what's expected. There are some things which I think will be of help, and there are also some things which I know will kind of perhaps make us think about exactly how we might practically implement them with the pressures on services at the moment. So this is just a copy of the document and the 7 principles they include. The principles, I think, are sort of fairly straightforward and things that very few of us would argue with. The things that I would flag up is to say that, look, there's a clear expression that the patients have a right to be involved in decision making about their treatment, and also to be given appropriate support to reach those decisions. Again, that's probably not surprising given what we know of the requirements of the Mental Capacity Act, etc. There's also a clear kind of use of this term of a meaningful dialogue, so it's expecting us to be able to evidence that we've had a meaningful discussion with the patient, and that we've listened to them, and that we've engage patients who might struggle with engaging with decision making as best as they possibly can. There are as I say, some things to think about. There is very much a focus on a meaningful discussion, and I'll try and expand on what I think that means a little bit later on. There is an express statement that says the signature on a consent form is not enough. Now, I don't want you to leave today thinking that that means that the consent form is worthless or not necessary. It's still, of course, an important document, and it's a really good place to set out the kind of risks and benefits of treatment, etc. But it's part of a process which also includes a discussion with a patient, which should be evidence in the records, knowing that you've tried to explore what's important to the patient, what they're fearful of, and to try and sort of integrate the discussion and decision making in that context. As the principles make clear, we need to support all patients to make decisions insofar as is practicable. And the other thing they also are at pains to say is that we should allow recording of consent discussions if the patient wishes. So do sort of bear that in mind. There are some reassurances as well as those challenges. There is a discussion of a proportionate approach, so the amount of evidence and time spent on obtaining consent depends on the circumstances, both the importance and the consequences of the decision, and also the acuteness of the situation. It's expected that even in acute situations, people who are conscious and who have capacity will be involved in decision making, but of course there's some acknowledgement of time pressures that apply in those circumstances and how that might limit both the ability to have that discussion and also the options available. There is an acknowledgement of the impact of resource constraints on our ability to have these discussions effectively, and there is also an acknowledgement that we often work in multidisciplinary teams, and it's also clear that it's reasonable for part of the consent process to be information provision by other members of the team. There's also some reassurance about how this guidance will be used in regulating doctors, with I think the GMC trying to say that we will not be judged against this guidance for being not able to be perfect on each occasion, but only for serious or persistent breaches in following it. I think again, cases at the GMC take many years to come to hearings, and it will take us quite a number of years from its implementation to know exactly how that means. In terms of the point about a meaningful discussion, well, these are my initial thoughts on what that might mean. It might mean that when you're making a note of that, when you're writing to the patient or their GP after the consultation, you of course normally would record what the patient's symptoms are. You might also want to include something about what their concerns about, what they think might be wrong, what they want to be the outcome of that, and what the priorities are, whether it's relief, immediate relief of symptoms, whether they're more concerned about a long-term prognosis or outlook, or whether they in fact want to avoid intervention. And also talk about what they would think would perhaps be the worst outcome from an intervention. And then when you're discussing risks, benefits and alternatives, the option of conservative management, putting it in that context. Now, as I said before, I'm a hepatologist, so the thing that I would most commonly consent for would be a liver biopsy. And say, for example, I might talk about the risks of bleeding, potentially of infection, damage to surrounding structures. Those are sensible sort of technical complications. But often we're using biopsies to resolve uncertainty, and I might record a discussion with a patient as to how important that is for them, whether they're happy to take a conservative monitoring strategy or they want to have a more certain outcome and they're willing to accept the risks of that for in inverted commas perhaps knowing. And I might take care in that setting to make clear that biopsy doesn't always give us an answer. So perhaps putting those into a letter will kind of also serve to evidence a meaningful discussion, as well as simply the kind of technical discussions we're all used to having about the risks of treatment. I guess we can't avoid the COVID context in discussions about consent, and I'm sure you, like I, have had many patients who either are concerned about the effects of COVID delaying treatment, or equally are concerned about coming up for treatment that you've recommended because they're worried about the risk of contracting COVID in hospitals. I think if you're faced with those, again, having a frank discussion, acknowledging the uncertainties, in particular of not knowing whether the situation would get better or worse, and acknowledging incomplete knowledge of the exact risk, whilst providing an estimate is a perfectly reasonable approach to take. And again, that might help fulfill documenting a meaningful discussion that you've engaged with that worry and you've addressed it as best as you can. So thank you for your attention. Thanks very much again for inviting us to speak today. I hope that was of interest, and please, if you have any questions, we'd be very happy to address them.